All right, 25 minutes before 11 o'clock. Thank you for tuning in this, Thursday, 1 week before Thanksgiving. Dr. Stephen Lamm is on the phone. He is, my goodness, his credentials go everywhere. He is the house doctor on ABC TV's The View. He's a contributor to Dateline, Oprah, Today, Nightline, Fox News. He's the director of the New York University's Men's Health Center. He's working right now. He's got patients waiting for him, so we might abbreviate the interview today. He's written a book called Redefining Prostate Cancer, an innovative guide to diagnosis and treatment. It is as scary a word as breast cancer or any cancer, really. Put anything that says cancer is scary to me. Dr. Stephen Lamm, good morning, doctor.
Good morning. Thanks for the fine introduction. And I think that it really is about patient care. It's about patient, from your point of view, about information. And I think that this book, I think, could be very helpful. I co-authored it with Herb Lepore, who is a leading prostate cancer surgeon. He's chairman of urology at NYU, and Dan Sperling, a really fine interventional radiologist who has devoted his practice to helping to diagnose prostate cancer. It's a big issue. As you point out, cancer is a big issue, but prostate cancer is the second leading cause of cancer death in men, and 30,000 guys die of it a year. It's not a nice disease to die with. So I think what we try to do is to help inform the average person about a condition that we all have to kind of deal with sooner or later, and not to be scared or overwhelmed by it, because the overwhelming number of men who have prostate cancer will not die of prostate cancer. They're going to die with it, not of it.
Oh,
That's
really?
what we're going to talk about. Yeah.
Is the man who does die from prostate cancer ignoring signs that you can tell us about? Is he living in pain and just refuses to go to the doctor?
No, it's not it. Here's what the scary stuff. Prostate cancer, for the most part, is a pretty asymptomatic condition. There are no symptoms almost whatsoever. What there are symptoms of are an enlarging prostate, and that people confuse that. And all men have an enlarging. When you're 50 and older, the likelihood of you sleeping through the night diminishes tremendously. You're not going to be sitting in a movie theater without having to go to the bathroom.
Right.
That's an enlarging prostate. Prostate cancers are sites within the prostate that have changed, that have been transformed into a cancer. And they can remain that way for 10, 15 years with no symptoms whatsoever. And only when it leaves the prostate and goes to your bones or goes to your liver that you then know that you've got a big problem. Okay? As long as it's within the prostate, it's essentially curable. Once it's outside the prostate, that's when you got to work to keep the patient alive and to enhance their quality of life. So this is, as I said, if you get diagnosed, it's not a reason to panic. It's not a reason to go crazy. You have the likelihood of you being alive 10 years from now is over 90%. So it's a very slow-growing, indolent kind of cancer. You have plenty of time to make the right decision.
So once it is diagnosed, have things changed as to how doctors treat it? Is surgery less happening less now than it was at one time?
Yeah, Larry, a really, really fine question. I think here's the point. That once, and this is what we emphasize in our book, it's that one size doesn't fit all. The first decision you have to make is, do you want to pursue the diagnosis? So, if you're 70 plus and you have diabetes, you have a whole bunch of other diseases, it's very likely that, unfortunately, you will have to address those diseases, because those are the diseases that are more likely to kill you than the prostate. So you may not even want to evaluate it at that age. Okay? If you're otherwise well and you have a likelihood of being alive in 10 or 15 years, then I think that it's worth pursuing. Okay? And the first thing you do is you go to the doctor. They'll do a rectal exam. Now, the rectal exam is also a rather poor way of diagnosing prostate cancer. It's a better way of diagnosing rectal cancer, but not prostate cancer, because most of these cancers you can't even feel. Unless you're Herb Lepore and you have magic fingers, it's not going to happen. Okay? So then you get a PSA test. A PSA is a blood test, which is called prostate-specific antigen. It is a lousy test. Okay? It's not specific. It's not sensitive. There's no level that tells you have cancer. There's no level that says you don't have cancer. But it is a signal. And if you go to a smart doctor, they will figure out how to use the PSA in order to determine whether more tests are required. If you all of a sudden go to the doctor and you got a PSA of 3, and then it's 4, and then it's 5, and then it's 6, there's a problem, okay? And you got to then, so it's the change in that level that's important. Then there are other few tests that might help with this. But then the decision might be, and what we talk about in our book, Redefining Prostate Cancer, is you can get an MRI, a fancy magnetic resonance imaging technique, not radiation, that in the right hands will be able to localize whether there is the likelihood of having a prostate cancer. If you do on the MRI, we can actually, at NYU at least, we can actually biopsy that lesion through the MRI and then make a diagnosis. Then depending on the type of cancer you have, there's some very low-level cancers that are best left untreated, okay, or just treated with a local, what we call local focal therapy. You know, I'm not trying to give a lesson in treatment of prostate cancer, no, but I'm trying to say that we have many options.
Right.
Of course, one of the options ultimately might be to remove the prostate. Another option might be to give radiation. And another option might be just to watch the patient. That's called watchful waiting. There's no other cancer that I know of where you can tell a patient you have cancer, but let's just watch it.
Let's just watch it, yeah. And is that because it's considered not aggressive?
Well, exactly. But here's the problem. It's not aggressive for most men, but how about for the 30,000 guys who die of it? You know, try to tell them that it wasn't aggressive. You know what I mean? So that's the dilemma. How do we find those guys and treat them aggressively while we leave the rest of the guys alone? In other words, if I said to you, we have 100 guys we diagnose prostate cancer, but 2 of them are going to die. But if we treat everybody, then obviously those 2 guys will live. But the other 98 are going to have to pay the price of having had surgery or other treatments that have. And that, how do we make that decision?
Yeah.
That's the controversy.
If a man has been diagnosed with cancer in other parts of the body and it's been technically cured, is there a risk for that cancer to flare up in the prostate in a few years?
No. And the prostate is not the site for what we call metastatic disease. In other words, when let's say you have a lung cancer, or you have a kidney cancer, or you have they don't go to the prostate. Okay, they go to bones, they go to liver, they go to brain. Okay, they don't go to the prostate. Prostate cancers, on the other hand, they're the ones who travel. They go to the bones. They can go to the liver. You know what I mean? It goes from the prostate to other tissues. It's not other tissues that goes to the prostate.
Oh, okay. I know you have patients, so you can decline this if you want, but there are some phone calls. Do you want to take some?
Sure, I'll take the phone calls.
Okay.
Oh, yeah.
All right.
Patients I love to listen to.
Okay, well, good morning. You're on the air with Dr. Lamm.
Yes, good morning, doctor. Are there any tests down the line in the future that would replace the PSA, which is not really that reliable, that a person could rely on later in life?
Oh, absolutely. I mean, you don't think the medical profession is going to accept a lousy test as its only test. So, right now we have another test which is called a PCA3. It's a urine test, and when you go to the doctor, and let's say you have an elevated PSA, they can gently massage the prostate for a couple of seconds, and then they'll give you a cup, and you'll get a sample of urine. The prostate cancer tumors release a substance called the PCA3, which you can then measure. And so if the PCA3 is elevated, that leads you to be a little bit more aggressive. So the answer is they're definitely working on it. And as I said, the PSA is a signal. It's the only signal we have. And until we get something better, it's no different that if you think about it in other things, in other areas, cholesterol measurements. So all of a sudden you get LDL and you get HDL and you get LP, you get other stuff that may actually be better tests. When they have been validated, then they replace the old test. Look at pap smears. I mean, now,
is it normal
for women? They would rather do the markers for HPV rather than the pap smear. So it is definitely an evolution in medicine.
For a person who has had radiation to take care of his prostate problem, is it normal to have a PSA reading because you still have your prostate in your body that still might be functioning to some extent?
Yes. I think what happens is the PSA then becomes a marker
Okay.
It's a marker to determine whether, with the radiation, you would expect the PSA levels to start to go down. They will not likely necessarily go to zero the way you would if you had surgery, but if all of a sudden your PSA declines, which we're all happy about, and all of a sudden it starts climbing and climbing and climbing, then you know you have a potential recurrence.
Thank you very much.
Thank you.
You're welcome.
The book is called Redefining Prostate Cancer, and it's the subtitle, An Innovative Guide to Diagnosis and Treatment. So it sounds like the word redefining implies that what we knew about prostate cancer 5 or 10 years ago is now different.
Exactly. What we're saying is that we redefine the approach, in the sense that for some men, we're telling you watchful waiting is good enough, and that you don't necessarily need either radiation or surgery, that we can be watched. Or we might say to you, we might try some innovative focal therapy where you can actually stick a laser into the area of the prostate cancer and zap it and watch it. So,
oh, wow.
You're really, you know what I'm saying? So rather than, that's a whole new approach.
And you have another.
I'm sorry.
You have another phone call. You want to take it?
Sure.
Okay.
Sure.
Good morning. You're on the air with Dr. Lamm.
Hey, good morning, Dr. Lamm. Really interesting, and I'll try to make the question as quick as possible. If you have no family history whatsoever, is there a possibility of this being a hereditary event? And the other question is, how old is prostate cancer? Is this something new to the environment or not? And I'll hang up and get your answer. And thanks again.
Thank you.
Sure. Great questions. I mean, I think that, we always view that there are genetic factors, in every cancer, because obviously it's the genome that somehow has been altered because of environment that all of a sudden, you all of a sudden have colon cancer. In general, we think of genetic transmission when everybody in your family's had a first-degree relative, like your uncle, your brother, your father, your grandfather. That's when there's obviously a genetic link, okay? But you have to remember the average man in 1900 lived until age 40 or 45, okay? And, they would never have had their prostate cancer diagnosed then.
Yeah, right.
And until we had the PSA, which was a screening test, most prostate cancers were diagnosed at a very advanced stage because there was no early screening, and they also didn't have, brachytherapy, they didn't have radiation therapy, they didn't have surgery. It was so a lot of, with the improved technology, surgical, radiation, and then the PSA screening, a lot more patients were diagnosed. Well, what we currently are suffering from is overdiagnosis. And, rather than we're diagnosing men that would have been better left well enough alone. Okay, and that's what part of what our book is all about. How do we find that man who would have been better off left untreated or better off treated? And that's what the book is all about.
And why are they not better off if they're treated? Is their sexual life
exactly.
over?
In other words, yeah. Well, how about this? There's collateral damage whenever we treat people with any drug, with any medication. Okay, there's no treatment that I can give you, unfortunately, that doesn't have some collateral damage. Some worse than others. So with prostate surgery or radiation therapy, you're going to have inflammation, or you're going to have erection problems, you're going to have bladder problems. Not necessarily. And with better techniques and better technology, I mean, if you get Herb Lepore to do the operation, you're in pretty good shape. Okay, but the bottom line,
I have to look him up.
I'm sorry.
I have to look him up. You mentioned him twice now.
Oh, well, he's a co-author, so, and he's chairman of urology at NYU, so I think he's great.
Okay.
So, and by the way, a tremendous supporter of the Men's Center, so I'm really appreciative. So I think that the bottom line is, yes, we have gotten much, much better, and we don't want to necessarily treat somebody who would have done just as well if we had not treated them, at all. I mean, you got to realize. Yeah, sorry.
If a person is in huge contact sports like football, is there, any risk that they will develop prostate cancer?
No.
More than somebody else?
No. I mean, the unfortunate football players have their own problems with the dementia and brain injury, and because of their obesity, these guys stay big and fat. So what do you think they develop? They develop diabetes and heart disease. But it's not necessary. And unless we want to say that obesity, is a risk for prostate cancer, and I think in some ways it probably is.
So does having sex often help or hurt?
Well,
I'm all
let's put
ears.
it this way. If I didn't know the answer, I would probably say it helps. Okay? And first of all, I will never acknowledge that it hurts. So I'm just telling you. If you want me to write your prescription for that, I'll do it.
Just have to find a place to fill it.
Honestly, I actually think it probably helps because I think it reduces some of the congestion in the prostate. So I think it's probably a good idea.
Yeah, got to get rid of that
And there
congestion.
may actually be some data on it, by the way.
I'd love
And
to
we
be
might
in that
even just have
study.
to make that up. I mean, what am I going to do, right? Sometimes you're going to make things up.
Well, thank you. The book is available here. I have a copy, so I want to give it away. If I have a listener who would like it, call me. And I know you've got patience, so I won't hold you much longer.
And in the future, if you want to talk about other men's issues, I'm more than happy to do so. I enjoy the opportunity to share my thoughts. I like good programs. I like good questions, and I like listeners. So it's not a problem.
There you go. Now, is there a website you can direct the listeners to?
Well, yeah. If they just, essentially, if they go to Stephen Lamm, the official website, you can see all the stupid, crazy things that I've done. But honestly, I just recommend that you go to Amazon and you just pick up the book and send it to your brother, your uncle. I think it's important for men to make a statement, okay, that we're finally going to step up. We're going to take better care of ourselves. And when you buy books about men's health issues, it's a statement that men matter. Look, women are so proactive. They're so good at supporting women's causes. Somebody writes a book on menopause or breast cancer or something, they buy it. Okay, we need men to do the same thing, and that gives the publishers and the television, radio reason for more men's programs.
There you
so,
go. Yeah.
This is not just a man's problem; it's a family problem. So, I really appreciate this time, and I hope we drive some of your listeners to get the book.
I think you will. Both those with a concern and those who maybe are just wondering about it. Dr. Stephen Lamm spells his last name
Thank you.
Lamm. If you're looking him up on Amazon, thank you, Doctor.
Thank you so much. Thank you all.
All right,
Be well, then.
we'll take a little break. We'll be right back.
You're listening to WOCA News Talk 1370, Ocala's source for what's happening in today's hottest, up-to-date news and topics.
Hey, I'm Gary.
And I'm Eric. Did you know that Red Eye Radio is on WOCA The Source every night from 2 to 6 a.m. and it's live?
That's right. No tape shows here.
We know that the news doesn't sleep.
And neither do we. So we're here with you live from 2 till 6 a.m. every weekday. Call us 866-90-RED-EYE. So join me, Gary McNamara.
And me, Eric Harley, every weeknight to discuss the latest in news and entertainment.
Right here on WOCA The Source.